My name is Selene Parekh. I was recruited to Rothman back in January. I'd been in practice for 17 years down in Raleigh, Durham, and came back to New Jersey. I'm originally from Jersey, so it's good to be back and great to be at a place like Rothman. We're going to talk about advances in foot and ankle sports injuries. And for anybody who enjoys sports, especially football, you know that every single weekend we're talking about these kind of injuries. So we're going to talk about some of the advances that we have going on. Here's some of my disclosures to review. When we think about athletes, athletes have injuries every single game, every single weekend, and they can plague them all the way from upper and lower extremities. About 213 million people in the US participate in sports or fitness activities, and they suffer about 8.6 million injuries per year. Almost the majority of these, almost half, involve the lower body. So we're going to talk about some of the more common ones, and ankle instability is something that's fairly common. If you look at Patrick Mahomes in the playoffs last season, he sustained this injury and hobbled him through the course of the last two games leading to the Super Bowl. But ankle instability, if you go back to your anatomy days, is basically an injury to what's called the ATFL, the anterior talar fibular ligament. It's marked by number 5 and 6 here on this picture here. And it's made out of type 1 collagen, spans the fibula to the talus, and helps to provide you stability. Our traditional ways of treating ankle instability in the operating room was either to take the native tissue and suture it back to bone, either through tunnels or through anchors, or we reinforce it with some of the local tissue, which wasn't necessarily strong, but it was better than no tissue to reinforce at all. There have been some novel products that have come out on the market trying to mimic the normal anatomy. So think about suture. It's stiff, it's rigid. Once you tie it down, it doesn't have any give, kind of like the left person here trying to jump off of an elevated height. If you have no give to that rope, you crash to the ground. But if you have elasticity, you kind of bounce back up. And so some of these new products have that elasticity built in, some of that normal tissue characteristics built into it. And we can use that to reinforce our repairs. So a synthetic reinforcement graft has come out on the market. I've been using it now for about 5 years. I was an early adopter of it, and it has transformed what we can do for patients. We can restore their anatomy and restore their stability and natural motion. That's great. But so could we do that before we use the reinforcement? These grafts resist necrosis, so they actually will turn into type 1 collagen native tissue over the course of 4 years, and they regenerate through natural tissue loading type of forces on it. So if we look at the reinforcement versus just suture alone, it's 92% stronger, but equivalent in the type of stiffness that we get with uninjured tendon. And this type of synthetic graft, like I'm showing in the upper right-hand picture here, becomes type 1 collagen, so normal tissue over the course of 4 years. And so what that means for us is we can take patients, and we used to immobilize them in a cast, non-weight bearing, for 6 weeks. But because I'm reinforcing their repair with a tissue that has dynamic nature to it, elasticity to it, mimics the normal tissue, I can actually let them walk on it 2 weeks after surgery. They can actually start therapy 4 weeks after surgery, and they can actually get back into their sporting type activities 8 to 12 weeks out from surgery versus 3 to 5 months. The next injury that can happen with that Patrick Mahomes type of inversion injury is a fibula fracture. Fibula fractures come in a variety of different orientations, and here are just some of the more common ones. But the end of the day, these are all fibular fractures that we have to worry about. And when we treat them orthopedically, we are trying to get that joint surface reduced back to its normal anatomy. We're trying to maintain the reduction or the alignment through their healing phase. And then we want to get this joint and that person moving as quickly as possible. The timing of the surgery does matter. And in traditional techniques, we had to really respect the soft tissues. So we could wait up to 3 or 4 weeks to allow the swelling to calm down so that we could do their surgery. But we know at about 3 weeks, the body starts softening up the bone. And so what we're trying to avoid is operating through soft tissue envelopes like this, these type of fracture blisters, the ecchymosis, the edema, because What we'd rather have is an ankle fracture that's not well aligned versus one where we've operated on it and the soft tissues have all fallen apart. So the question was, could we do this kind of surgery in a different way? When we do it with traditional options of plating, we wait 6 to 8 weeks after the surgery to walk them because we want this large incision to heal enough before we can let them to walk. So we want the plate to be able to get the reduction. We want the soft tissue to heal, and then we get them to walk. So usually about 6 weeks. What has happened over the last 7 years is these fibular nails. And the creation of these nails has allowed us to do these surgeries quicker, sooner, and without making big incisions, which means I don't have to wait for the swelling to go fully down. I can get to these patients in the operating room within the first week of their injury and make small incisions like you're seeing here on the right-hand side and put this nail right up the fibula and be able to hold a fracture where I want it. So the typical plate pictures on the left, the typical nails on the right, you can see the difference. We can get these patients in the operating room sooner, which means we can weight bear them faster because we don't have to have that big incision heal enough to wait for them to weight bear. Oftentimes, I will let these patients walk on it either the day of or 2 weeks out from surgery. They're out of their boot 4 to 6 weeks out of their surgery, and then they're back into their activities. This is a patient of mine who's 29 days out from her surgery, had a bimalleolar ankle fracture, meaning she had a fracture on the fibula as well as the medial malleolus. This is not something we could have done for a patient before having this type of technology. And there are stories of this type of nail being used in athletes, and the athletes are coming back in the same week to playing, especially in hockey or skiing, where you're really locking down that ankle. The next type of injury that can happen with that inversion type of motion is a Jones fracture. A Jones fracture is a fracture of the base of the fifth metatarsal. It's basically where the fracture comes out through the interaction space between the fourth and fifth metatarsal. This is a fairly common foot injury. The fifth metatarsal is subject to repetitive loading. And so our typical way of fixing this is with a straight intramedullary screw, a screw that goes right up the bone. But you can have issues develop with a straight screw going into a curved bone. So take a look at this left x-ray and you can see that that fifth metatarsal is curved. And this is not even one of the more severe curves that we can see. So if you have a straight bone, a straight screw going into a curved bone, that anatomy doesn't always match, and that can lead to problems. One of the problems is being able to fill the canal. If it's bending and you're trying to go straight, you can't get that canal fully filled. And so you have a screw that is not optimized mechanically. That can lead to a non-union or delayed union of that fifth metatarsal fracture. And you see that in that third x-ray to the left. And then sometimes you're putting that straight screw in and you break through the more distal or the more far end of that fifth metatarsal. And now you suddenly went from having one fracture to two fractures. And that's a problem as well. So one of the solutions I've helped develop is another intramedullary implant similar to the nail that I helped develop for the fibula. And this is called a Jones bolt. This is basically a curved intramedullary implant that has wings on it that allows the attachment of the far end of the metatarsal. And so we can get this kind of implant in with one implant. There's not a lot of choices. We can have it curved so it fits the anatomy better, and these patients can heal quicker. And we've seen that in some of the research we've done on this. So that's the Jones fractures. Now, when we move from the outside of the ankle and the foot to the back of the ankle, that's where we start talking about Achilles tears. And if you follow sports, this has become something that's been a hot topic globally. And the reason why it's been a hot topic is this specific athlete here. So Aaron Rodgers, Monday Night Football, first game of the season this year for him, ends up with, in this play, rupturing his Achilles tendon. If you're a sports fan, you know that almost on a weekly basis, Aaron has been in the media talking about his expedited recovery. These injuries can occur fairly easily. In the course of the season, we've seen Kirk Cousins have this injury. We've seen Cam Akers yesterday have a second injury as well. And some of the controversies around these injuries is, do you treat it operatively versus non-operatively? And if you do surgery, are you doing it open? Are you doing it through small percutaneous incisions? Are you adding something to it to augment the repair like you would for the lateral ligament? Or how are you rehabbing these patients? So we know men get these more often than women. 80% of these injuries are men versus women. The average age is 42 years, but I think that's going to be increasing with the advent and also the popularity of pickleball. 68% of these Achilles tendon ruptures happen during sports, and there are contributing factors that we know exist. If you're over the age of 40, your tendon is more stiffer. It has less blood flow. If you're male, you're fivefold increased risk. Prior rupture rates put you at a higher risk of re-rupturing. Steroid injections around the Achilles and medications like fluoroquinolones and statins can all increase your risk of an Achilles tendon rupture. Now, one of the more famous injuries of an Achilles tendon rupture, or an athlete who had this, was Kobe Bryant. And he had one of the more traditional ways of doing it, which was this big, long incision like you see on his left ankle here, which was fraught with complications. When we had these big incisions, just like with the fibula, you have to wait for the soft tissue to heal before you can really get them mobilized, which meant that they're in a cast usually for 6 weeks. And even still, the wound complication rate was 10 to 15%. And sometimes that meant multiple trips to the operating room. Not an ideal situation. So this is not something we do anymore. And over the last decade, this is a technique that I've evolved into, using standardized instruments that we have in the operating room, where we can make this mini open incision in the back of the rupture. We can grab the stumps of the tear. We can actually throw sutures while we're looking at it right through those stumps. We tie the stumps together, and then we can reinforce it with what's called an internal brace or a suture bridge. So if you follow this dark blue line, it's basically a very stiff suture tape that goes from the proximal stump and anchors right into the calcaneus. And by doing that, you bridge over the repair site and you protect it, which means that you can mobilize these patients faster. So 2 weeks after surgery, I am now letting these patients walk on it in a boot. 6 weeks, they're out of their shoe and they're working with therapy. And we've seen pro athletes. Cam Akers came back 5.5 to 6 months out from his Achilles tendon rupture. I didn't do a surgery, but he came back in 2021, 5.5 to 6 months after his surgery, and played in the NFC Championship game. This is a patient of mine, an NFL player, who shared this on social media, gave me the okay to share it as well. And I want you to watch this.
Keep going. When they tell you you can't, come on, man. Who are they? When they tell you you're not going to make it, don't believe them, man. Don't believe them. You got to be relentless. Don't give up. Don't give up. Stay in it. Stay focused. Quitting guarantees the failure. Once you quit, it rules out any chance of succeeding. The mere waking up every...
So this patient, this athlete, 4.5 months out from his repair that I did, is doing these box jumps. That's tremendous. We never could do that before without this reinforcement internal brace technique. And that is what Aaron Rodgers got. And so 4 weeks out from Aaron's surgery, he's doing this. He's throwing. Now, he towards his left Achilles, he's not bending it much. He's far from being ready to get back into the playing field in a real game. But the mere fact that he can do this 4 weeks out from surgery is tremendous. He keeps saying he's going to be back this season. I think he will, from his willpower. I think he's going to come back no matter what. How effective he is a different story, but I think he's going to be able to do it, and that's pretty amazing. The next topic I want to talk about is peroneal tears. These are fairly common and are one of the reasons why patients have lateral ankle pain. There are some famous athletes who've had peroneal tears. Curt Schilling, back in the World Series years ago, had the bloody sock, where he had a peroneal tear, but also had a peroneal subluxation, where the peroneal tendon was popping over the fibula. And the sports medicine guys at that point were just percutaneously suturing the tendon back into place before the games. And he was bleeding during the game. I mean, he had this in the locker room before his game. So this was famous because of the bloody sock. Von Miller for the Broncos had this injury as well. But peroneal tendon tears are a common source of lateral ankle pain for patients who've twisted their ankle but continue to have lateral ankle pain. Many of these go unrecognized and they get misdiagnosed up to 40%. So early recognition and repair is associated with good results. It becomes a little less predictable, your surgical outcomes, when you start talking about chronic degeneration or the involvement of two tendons or tears that are over 50%. And so there are some options that we're going to talk about. But remember, the peroneal tendons, there's two of them. They sit on the outside of your ankle. They hug the posterior or the back part of the fibula. There's the brevis and the longus. The brevis sits right against the bone. The longus is behind that. People can end up with tenosynovitis and tears. This can happen from a trauma, from overuse. They can have a hypertrophy of their peroneal tubercle. They can have inflammatory arthropathy, or they can have something called an injury to the os peroneum. These patients typically will present with posterior lateral ankle pain that's worse when they're cutting or twisting. And on exam, we'll see tenderness to palpation over the peroneals. They may have some thickening. They may have pain with passive inversion or resisted eversion. And sometimes you can actually see the tendon dislocate out of its groove. So we'll do imaging, which includes x-rays. Maybe you'll get an ultrasound, maybe an MRI or a CT scan. In the US, we don't do ultrasounds very often because it's user dependent and MRI is so readily available that that's our preferred advanced imaging. You can try to treat the inflammatory processes of the peroneals conservatively. You could do it with immobilization. You could do it with a boot. We don't oftentimes do a steroid, but if we do, we're going to immobilize them after the steroid to decrease the risk of rupturing that peroneal tendon. PRP injections have been described. There's no real data to support it, but patients have usually, I do have some patients who've gotten that done elsewhere. You can also try these lateral heel posts, physical therapy, anti-inflammatories, and activity modifications. But at the end of the day, a number of these patients end up in the operating room. In the operating room, what we're doing is going in, cleaning up the tendons. We're looking at both of them, always looking at both the brevis and longus. We're cleaning up the tendons. We repair them if we need to. We may augment them, and we may actually deepen the bony groove behind the fibula. So if the MRI shows that this is just an inflammatory process, that there is no tear or there's a tear questionable, what we can do is tendoscopy. We can basically scope the tendon sheath. And here you're seeing the brevis and longus. That's my metal probe. And on either side of me, one's the brevis and one's the longus. And you can see it. And there's some redness around the upper part of that picture on the bottom. That's the inflammatory tissue. I can take a shaver and I can clean that out. This is a lineman, an NFL lineman who had an ankle injury, and he could actually dislocate the tendon for me, the peroneal tendon for me. So this is dotted line is the incision we make right behind the fibula, and he had torn the retinaculum, that tissue that helps to hold the peroneal tendon in place. He had a tear of his peroneal tendon, which you're seeing on the right hand side here, and we repair it with suture to bring those two ends back together or tubularize the tendon itself. The question becomes, well, these tendons run in a tunnel, and that tunnel has a certain volume. So is there anything we can do in the operating room to give them more space, more volume in that tunnel to take pressure off the tendons? And we actually can. We can deepen the groove behind the fibula. So the way we do that, the way I do it, is I'll actually take a drill and run it right up the medullary canal of the fibula. And then the upper right-hand side, you can see this metal tamp that I'm holding, and I'll actually impact it and collapse that cortex of the fibula, creating a groove in the back of the bone. So now I've deepened the tunnel, which means the volume of the tunnel is increased, which takes pressure off the repair, and that's been shown to help decrease the irritation that happens post-operatively. I had said that one of the etiologies can be a hypertrophic peroneal tubercle. So this is an MRI showing the hypertrophic tubercle. It's this jutting out that you're seeing on the right MRI, kind of on the lateral side of the fibula. And on the coronal view on the left MRI, you'll see it jutting out laterally on the calcaneus as well. So in the operating room, once we see the fibula and we see the peroneal tendons, you can look at the peroneal tubercle. This is a rongeur, looks like a pliers, and we're nibbling the peroneal tubercle away. We can take an osteotome and shave it away as well. And then when we're done, we close this all up and close the skin. So how do these patients do? Well, a lot of them can have persistent pain. They can recur they can have a tear that recurs, and they can have progressive tendinopathy or degeneration of the tendon. So the idea in orthopedics was, could we do other things to help the outcome? So concepts have been derived from allograft, whether it's skin-based or amniotic tissue, or xenograft, whether it's porcine, bovine, or equine. And the idea is, could we be able to wrap these tendons and decrease the scar formation that can sometimes irritate the tendons later on? And the data is unclear on it, but it is something that we are looking to do to try to minimize adhesion formation. So here's a patient who has a tear. We tubularize it. What's in the gridded paper there on top of it is a slimy layer of amniotic tissue. We can wrap it around our repair, and the idea is it brings an anti-inflammatory covering around the tendon, decreasing scar formation. And this is what it looks like once we've wrapped it and sutured it. So many times these patients get their primary repair, and then they have a recurrent or a chronic tear that develops. So the idea is, what do we do with this? And people used to just do perineal tenodesis, which means you've got two perineal tendons, one's torn. You're going to take away the part that's torn. You're left with the proximal and distal stump, and you basically tie it to the remaining perineal tendon, which means you have two muscle bellies functioning through one tendon structure. And that's been shown biomechanically through this paper that we had done, showing that biomechanically, that option is not good as having two muscle bellies, two tendons. And that makes sense. If you only have one tendon working with two muscles, it doesn't work as well as having two tendons working with two muscles. So perineal tenodesis is not something I do anymore. When I first started my career, I did this because we didn't have options, but now we have some other options. One option is to see if we could take one of your other tendons, so the patient's other tendon, to replace the bad tendon. So this was a technique described by one of my mentors where you can take the FHL tendon and be able to take it from where it belongs and put it to where the perineal acts. So the idea here is, by doing this FHL tendon transfer, you recreate the dynamic eversion of the perineals, but you will lose one level of strength of the perineal, because anytime in orthopedics we take one tendon and move it from one area to another, you lose one level of strength. You also will lose the function of the FHL. So the idea here is, you can go in, you can make this same incision like I showed you before. This is a patient who already had a repair once that failed. You go in, you clean this all out, you free up the tendon sheath, and then we do something called a hunter rod. It's a rubber rod that you put into place where that perineal tendon used to be. And you close up the tendon sheath, and you allow patients to move, and this allows the tendon sheath to recreate itself. You let them walk on it, and then 3 months later, you come back to the operating room to do the FHL tendon transfer. So you bring back to the operating room, you harvest the FHL tendon, which we're showing here, and then you'll actually take it, attach it to the proximal part of that rubber hunter rod. You pull the hunter rod out, the FHL tendon follows it, and then you tie the FHL back to its stump. We looked at this, 7 patients had this done, 5 had excellent results, 1 had good, 1 had poor. But the problem is 2 surgeries, 2 anesthetics, 2 recoveries. Not ideal. So the idea is, could we do this in some better manner? And that's where we talk about allograft or autograft reconstruction. So here's a patient that had both the brevis and the longus were torn and degenerated, and we replaced both of them with a semitendinosus allograft, basically cadaver semitendinosus graft that we can then use to recreate the bad tendon. You cut out the bad tendon and you suture in the allograft. And this is me actively doing this. We have multiple ways that we can tie it into the remaining stumps. And this is where I'm tying it into the proximal stump. Here I'm tying it into the distal stump, and I've recreated the perineal brevis through this technique. So I've cut out the bad segment and put in the allograft. So we looked at 14 of our patients. We looked at outcomes. There were no wound complications, infections, or re-ruptures. 6 out of the 14 had high-resolution ultrasound to allow us to see if these allografts are gliding. All of these patients, all 14, were able to return to their pre-injury activity level. And we looked at patient-reported outcomes, their functioning, their SF-12 scores, their pain scores, all improved statistically significantly. So these patients are doing better when they can have two tendons, two muscle bellies, to function the way they were supposed to function. Their strength is better as well. So the question then is, okay, if we know that we have two tendons that work better, two muscles that work better, what happens to the patient who had a tenodesis back in the past? Can we reverse that? So I've had 3 patients who had tenodesis done, and they were having pain and they were having problems. They didn't like the fact that they didn't have normal motion. And we went back and we reversed the procedure where we gave them 2 tendons back. And this is what it looks like. This is a patient that I brought to the operating room. And by the time we came in to reverse it, the longest had also started degenerating. So I went ahead and I did an allograft of both tendons. And these patients are functioning well. So what's out there is, you know, do we just do this right from the beginning? Do we forget about doing a repair and we just do an allograft reconstruction? And I used to think about that until we had access to the same material that I showed you with the lateral ligament reconstruction. So this is what I do now. Instead of going in primarily and doing the repair, just kind of tubularizing that tendon, what we will do is take that synthetic graft, and you'll see that that's what's up here in the upper right-hand picture. You're seeing it kind of coming off the tendon. And we put that and suture it into the center of the tendon. And then we take the tendon, the native tendon, and we tubularize it around the synthetic graft. So that synthetic graft now becomes the core of your repair. And the idea here is you're bringing strength, you're bringing biology, and this tissue, this synthetic graft, will become type 1 collagen over the course of 4 years. So the idea is we're bringing some biology back, and we have not yet started going back to look at how our first 3 years of these patients have done. But the idea is that maybe we can decrease the recurrence rate, the chronic tendinopathy, and allow these patients, these athletes, to have one surgery, do well, and never have to worry about this again. So in general, in the athlete, I don't do a tenodesis. In general, I don't do it at all in my practice anymore. I don't recommend an autograft because I'm taking one of the patient's normal tissues and making it do something else. And so they're going to lose function of that normal tissue, but they're also going to lose one level of strength to the transfer. I'll do the Artelon, which is that synthetic graft. I'll do an allograft, but I don't do any of those other procedures. So in general, the care of athletes continues to evolve. I'm just showing you a sampling of some of the technologies that are entering foot and ankle to allow us to get athletes, patients, people back to doing the things that they love quicker, faster, sooner, more efficiently. They're not all going to be playing pro sports, and they're not all going to be highly active, but they all do want some quality of life back. And if we can do that in a way using surgical techniques or technologies, then I think that's important. And it's one of the reasons why I was recruited up to Rothman to help bring us some of these techniques to the area and to New Jersey, where not a lot of these things were being offered to the foot and ankle athletic population. So with that, I'm going to open up the floor to questions, whether it's the chat box or verbally. Anybody has questions, I'm happy to answer any questions. I can, there's some questions in the chat box that I can start answering. Can collagen supplements help with Achilles tendinopathy? That is a great question. The real answer is that there's no data on it. So I don't know. I can't give you any data on it. Most of my patients have not tried collagen supplements. Collagen supplements that have been tried for, say, osteoarthritis. The data on that is mixed. So for Achilles tendinopathy, I'm not sure how it would work, but certainly not something that is harmful to try. Another question is, what do you recommend for bunion surgeries, and what is the success rate? Bunion surgeries, first of all, just because you have a bunion doesn't mean you need surgery. I tell patients that when their bunion is to the point where shoe wear becomes problematic, or you're having more bad days than good, that's one indication for having surgery. The second indication for surgery is when the big toe is leaning on the second toe and causing pressure on it. Don't wait for deformities of the lesser toes, but when that big toe is hitting the second toe, that's another reason to have surgery, because the surgery is much easier to do when it's isolated to the big toe than when we're doing lesser toes. Um, when you ask me the recommendation for bunion surgeries, it really depends on the type of bunion. So what we've learned in orthopedics and foot and ankle over the last 10 years is that their bunion isn't just the leaning of the big toe on the second toe. Some bunions can actually have a rotational deformity to it. So what I mean by that is if you look down, if you have a bunion, if you look down at your big toenail, if that toenail is rotated, you not only have a bunion, but you have a rotational bunion. So it all depends on the type of bunion you have. And some can be treated now with minimally invasive surgery techniques where we make 5 small incisions about 5 millimeters, 6 millimeters in length. We cut the bones the way we need to, realign it, hold it in place with some screws. And some others need, and those patients can walk on it immediately. And some bunions require us to do fusions of joints. You may have heard of something called the Lapidus procedure or Lapiplasty. That's kind of a big term that's been going around in the media for the last 5 years. It's where we fuse one of the joints. And those patients do need a period of non-weight bearing. So it all depends. Regardless of the rate, the success is usually about 90% success rate. I tell patients there's about a 10% recurrence rate in the course of your life. And that can happen early or late, but you can have about a 10% recurrence rate. Next question is, what is the success rate of tarsal tunnel surgery? Really good question. It depends on what the driver is. And what I mean by that is the number one reason for tarsal tunnel syndrome is a ganglion cyst in the posterior aspect of the ankle pushing on the tarsal tunnel. If that's what you have, resecting out the mass and doing a tarsal tunnel release gives you 90-95% success rate or better. When you're doing it for an idiopathic reason, meaning you're not quite sure what it is, but the patient has tarsal tunnel symptoms, whether it's because of tortuous veins or because of increased pressure from unknown reason, those don't do as well as they do well, but not as well as a mass effect. And we looked at our patient cohort where we did a tarsal tunnel release, and you're looking at about an 85 to 90% success rate in those situations versus, I would tell you, with the mass, you're looking at 90 to 95% success rate. Next question is it possible to repair an injury from 10 years ago that hasn't responded to PT shots or even surgery? I'm not sure what area of the body you're talking. I mean, I know foot and ankle, but I don't know what kind of injury. So I think I would respond to that saying it depends. Depends on the injury, depends on what surgery was done, and depends on kind of what we're dealing with. So I'm happy to answer that with more information. The next question is, I love and appreciate your scientific and data-based approach to being an early adopter of promising new technology in orthopedics. What are a few of the most exciting technologies not yet out or that I anticipate on the horizon, making a big difference in patient outcomes? Make sure I give a shout out to my son's Amazing Sports podcast. Okay. So on the horizon, I think are the continued evolution of minimally invasive techniques. I showed you for the fibula what we've helped design for the Jones fracture. I've shown you some of the synthetic grafts that are out there. I think what we're going to start seeing over time is novel materials entering foot and ankle that we can use in a minimally invasive technique so that the soft tissue disruption to the athlete or the patient is much less. And which means, again, just like we're seeing now, quicker, faster, more efficient recoveries. And for the pro athlete or the competitive athlete, that means getting back into your sport sooner. The shout out to my son's podcast. So my boys, I have 2 boys and a daughter. My 2 boys are now 16 and 15. At the start of COVID, so we're a big sports family. At the start of COVID, they were in the middle of the night arguing about some kind of NFL something or the other. And my wife went in the room and said, listen, you guys need to sleep, but if you're that passionate about it, start a podcast. And that planted the seed. They started their own sports podcast. It's called Two Brothers and Their Sports. It can be found on any podcast platform. It's ranked in the top 5% of podcasts now around the world. They've been doing it weekly for the last 3.5 years. They're like the Mike and Mike of teenagers. They have pro athletes on there that they interview, coaches, conditioning people, sports psychologists, even Olympians. And so check it out. It's called Two Brothers in the Sports. Thanks for that question. Does a steroid injection into burial sac for retrocalcaneal bursa put you at risk for Achilles tendon degeneration or rupture? I worry about any type of steroid shot in and around the Achilles tendon. So my answer to you is going to be, you must be careful. So I have done retrocalcaneal bursal injections of steroids, but I will put them in a boot, allow them weight bearing, but I will keep them in a boot for a month to protect that Achilles tendon location because I really want to minimize the chance of a rupture. And so I don't think that the steroid has to be in the tendon sheath to cause the rupture. I think even in the retrocalcaneal space, you can put the tendon at risk. So I think you have to be careful. Next question is, how long does it take to recover from bunion surgery? Again, that will depend on the type of surgery you have, but I'll give you kind of an umbrella idea. About 8 weeks before you're back in your shoes. For the first 8 weeks, you're in a post-operative shoe or a boot. Then you're back in your shoe normally about 8 weeks. But remember, pain, swelling, motion, function all continue to get better for 1 full year. That's for any foot and ankle surgery. So even though you're back in your shoes, your function will continue to recover. Your swelling continues to get better, and those continue to happen for up to a year. Next question is, can you talk about your functional rehab protocol for lateral ankle instability? So for patients who have lateral ankle instability, if they are not a pro athlete, I will keep them in a cast non-weight bearing for 2 weeks. And then at week 2, they're in a boot, walking on it. I'll let them do alphabet exercises. And then at week 6, they're out of their boot, working with the therapist on motion, strength, mobility, agility, all that stuff. When I have a competitive athlete at the collegiate level or at the professional level, then I'm a little bit more aggressive for a number of reasons. One is that they have somebody watching them at all times, or mostly all times, and they can get access to care every day with the athletic trainers or the physical therapists. So in those situations, I will allow these athletes to walk on it the same day in a boot. And then I will, at week 2, let them start coming out of the boot and doing some range of motion exercises. I'll even have them start doing some in-line, straight type of exercises. By week 4, I'll allow them to start doing some early cutting exercises. And by week 6 to 8, depending on the sport, they can start doing sport-specific activities. And so it's a much faster recovery than when we did not use the dynamic stabilization techniques. Any specific instructions I give my physical therapists? Yeah, with all my physical therapy prescriptions, they're fairly comprehensive, usually page long, week by week, of things that I want my trainers to work on, my therapists to work with for the patients. And that's both for operative, I'm very particular. For non-operative, it's a little less particular. And then I do allow the therapist to have leeway on modalities that they feel would be helpful to the patient. I think I talked about the technique for weekend warrior versus pro athletes. When do you use PRP or BMAC in an acute setting to accelerate healing? That's interesting you said that. PRP, so my thought process here, bone marrow aspirate gets stem cells, PRP gives you platelets. There's an inherent difference. Platelets are like a shopping bag full of all these different things in it, growth factors, but it's not really smart. And what you're doing is trying to inject a lot of PRP at a high concentration, let those shopping bags pop open and dispense all of the growth factors that are in them, and letting the body then try to figure out, well, all these growth factors are around me. Now I got to figure out which ones I need and don't need. To me, that's kind of dumb technology. I like stem cells much better, bone marrow aspirate. Well, let me back up. Not necessarily bone marrow. It can either be bone marrow or lipid-based. But I like mesenchymal stem cells much better. I find them much smarter. And what do I mean by that? The stem cell is a cell. It's got sensors all around it, receptors all around it. The idea is taking high concentration of stem cells, either from bone marrow or lipid, injecting it into the area of concern, and then allowing the receptors on the surface of the stem cell to figure out what does this environment need so that I can produce whatever proteins and modulators I need. That I find much more esoteric. I find it much more smart than PRP, and I think it works much better. So I've had a lot of success rate using bone marrow aspirate in areas of non-unions or fusions, and I've had a lot of success with lipid-based stem cells for inflammatory problems, joint arthritis, tendonitis, plantar fasciitis. And I think that's kind of how I think about the regenerative medicine world for these technologies. Next question is: are your post-surgical rehab protocols utilizing Ardilon versus a non-stretch internal brace for lateral ankle stabilization equivocal? When would you dictate using one versus the other? So I used to use the suture-based technologies early on because they came out before Ardilon was available, and I thought I liked them. The problem was that there's stiff and rigid, so there's no give to it. So like I showed in the picture, you're taking normal tissue that has elasticity, and now you're getting rid of it with a suture-based technology. And what I found is that over time, these sutures could bother patients, and I'd have to go back in and another surgery, take the stitches out. And so I stopped doing it. And then Ardilon came along, and that just made a lot of sense because it had the dynamization to it. It had the ability to become type 1 collagen and kind of be normalized into regular tissue. And so my whole practice for dynamic stabilization for lateral ligaments has moved to a synthetic graft dynamic stabilization product. Next question is: does a Medrol dose pack for foot bursitis and insertional tendinopathy put you at risk for Achilles tendon rupture? I am so oral steroids. I'm not sure that puts you at risk for Achilles tendon ruptures. I think it's more about the injection, and we don't understand why, but that injection in and around the tendon, that's what puts you at risk, not the Medrol dose pack. However, I have taken care of a lot of avascular necrosis patients, of the talus specifically. They come in from around the world, and so many of them have been on steroids for a variety of different reasons. What we still don't know about steroids is how much do you need, how many exposures, what duration of time. And for me, I exceedingly rarely want patients exposed to Medrol dose packs because I just don't know what kind of damage we're doing to their blood supply in whether it's the talus or the femoral head. So in my practice, there's almost no role for a Medrol dose pack because I do take care of so much avascular necrosis, and we use the 3D printing for the limb salvage to take care of these patients, and that's a big problem. Next question is there an alternative to Lisfranc fusion surgery to give relief after ORF surgery that has left me with pain in multiple areas and also nerve pain issues? Yeah. So the Lisfranc data. So if you go back about 15 years, there was a paper that came out of Minneapolis that talked about doing fusions for Lisfranc injuries and those patients doing better than the ORIF. That paper is so misquoted because it was a very small subset of Lisfranc injuries that applied to. And it was really meant for those patients who had purely ligamentous damage Lisfrancs versus bony related Lisfrancs. And so, and even those authors over the last 15 years have tried to changed their recommendations. So for me, ORF of Lisfrancs is almost always what I'm doing. Fusion is really for salvage. If you're somebody who had a Lisfranc ORIF or a fusion and you have pain, I think there are multiple things you got to think about. And obviously, I can't give you medical advice on this, but things that you should be thinking about are meeting with pain management, meeting with neurology, maybe acupuncture. There are, from the functional medicine world, there are a lot of athletes who are using these light-based patches to try to help with pain management. And there are reports of that helping quite a bit for patients. But again, that's more from the functional medicine world. And so I think looking for some options that address nerves is something you probably do with your healthcare providers or a functional medicine specialist. Next question is, as a patient who had a 12-week recovery for a fractured foot, is it normal to have an uncomfortable feeling in that area still? Yeah, I mean, I tell patients that up to a year after any type of foot or ankle surgery, expect that you continue to have improvement in pain, function, swelling, numbness, tingling, all of that stuff. So if you're only 12 weeks out, that's still way early in that 1 year timeline. And I think that you shouldn't be alarmed by that, but you absolutely should talk to your healthcare provider if you are concerned. You wore a boot for 7 weeks. I can walk okay. Okay. Next question is, are you performing BMAC in the office setting? Where are you taking it from? So BMAC in the office setting is extremely painful. If you take bone marrow aspirate, either from the iliac crest or the tibia or the calcaneus in the office, that can be so much more painful than the reason why you're doing it. So I do not do that in the office setting. Bone marrow aspirate is done in the operating room. Like I said, I do it for fusions and I do it for fractures, but I don't do it for the inflammatory problems. So that's done in the operating room. I typically will take it out of the heel, and it seems to work well. The lipid-based stem cells, mesenchymal cells, that can be done in an office procedure. And we did offer that in my old practice. Rothman, as of today, is not offering that, but it's something that we are exploring to offer at Rothman. There you go. The next question was, can you elaborate on liposomal mesenchymal stem cells? So the way we do it is we do a liposuction right in the office, and then there's technology to micronize that fat, which means you kind of make it into a lot of tiny little particles, and then you concentrate those particles down and you re-inject it into the joint or the plantar fascia or the tendon areas. And I've had a lot of good success with it. The whole procedure takes about 45 minutes. The downside to it is that that is not covered by insurance and is an out-of-pocket expense. Next question is, please comment on prolotherapy for ankle issues like insertional tendinopathy or any other conditions. Prolotherapy is basically, for those who don't know, it's basically where you will inject typically saline or any kind of fluid either around tendons to try to break up scar tissue or in a joint to kind of expand the joint to help free up some of that joint. It's not something I do. I know chiropractors will do that. I think some of the DPMs, I believe, may offer that as well. I don't offer that. I have taken care of a number of patients who've had that done and weren't thrilled with it. The data on that is mixed. So it's not something that I offer or necessarily feel like is very effective for patients. Any other questions, either through the chat or live?
Okay. Oops, we got one more message came out.
All right. For talar tibial osteochondral lesions and ankle arthritis, any use on alpha-2 macroglobulin? A great question. That's really, again, more functional medicine guys that have access to it. Again, that's all being done without a lot of data. And so those are kinds of technologies that you'll find in regenerative medicine clinics or by functional medicine physicians. I don't have enough experience with it to be able to tell you much about it because I don't do it. But it's something that if you're seeking that, you can certainly look for individuals around here who do that. Hyaluronic acid, HA has not been approved for use in the ankle or the foot by the FDA. The reason for that is it's off-label usage. That off-label usage that has been done has shown that it's not very effective, whether it's for ankle arthritis or even for big toe arthritis. I've had patients who paid out of pocket to try to get that done off-label, and my personal experience has also been the same, that it is not effective. So it's not something that I would recommend to patients. I think if you're going to go down that path and you're going to try something that you're going to end up paying out of pocket, that you probably want to try something from the regenerative world, like lipid-based stem cells, like some of the alpha-2 macroglobulin and things like that versus HA.